I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about hormones and breast cancer and longevity and all of that great stuff. But before I get into it, a few things I want to make clear. One, this is not any type of medical advice. So if you have any questions about your health, please speak with your friendly neighborhood healthcare provider. And if you have any questions about your religion, make sure you go speak with your religious leader if you have any questions. But this doesn't have anything to do with religion. So this is a super exciting podcast, and I'm so excited to have on with me Dr. Sarah Glynne. And Dr. Sarah Glynne comes to us from England. So Dr. Glynne, welcome. Thank you so much for coming on to the podcast.
Thank you very much for having me. It's lovely to meet you.
Yes, likewise. So for those individuals that may not know who you are, if you could please introduce yourself to all the listeners and viewers out there.
Sure. Yes, I'm a GP menopause specialist. So my background is briefly in hospital medicine and then for a longer time in general practice. Primary care, I'm not sure if you call them, I don't think you call them GPs in the US.
Yeah, we call them. Primary care, yeah.
And then for the last, 5-ish years, I've been focusing solely on menopause care. And I have a clinical practice in London, but I've also had an academic role, and I've published some papers recently. And I'm very interested generally in very sort of clinically focused papers that are likely to hopefully change clinical practice. That's sort of my area of specialty.
Yeah, I mean, you are so well published, and I'm really excited about having you on. So let's get right into it. So now you've worked extensively at the intersection of menopause and breast cancer. Can you walk us through a particularly challenging case that possibly helped you shape your clinical approach?
It's really hard. There have been so many cases, and it's really hard to pick one because every woman's history and story is so completely different. I think I got interested in breast cancer because when I was starting out in menopause, I found that I was spending a lot of time in my consultations talking about HRT and breast cancer. Yeah. And then I started to meet people and obviously become gradually more familiar with the literature. And I started to be aware that there was this sort of black hole in menopause care, really, when it comes to women who've had breast cancer and HRT. And I've heard over the years some terrible stories. I always sort of recall one lady who I saw a couple of years ago, and she'd had breast cancer when she was in her mid-30s. So she'd been quite young, but she'd done really well. She'd had it treated. She'd finished treatment. Her periods had come back. She'd been menstruating once a month for 10 or 15 years. And then she'd hit the menopause like a brick wall. And she was single. She wasn't married. And she worked in an advertising PR type company with lots of young people. And she was experiencing frequent debilitating hot flushes, night sweats. She couldn't sleep. It was affecting her confidence. It was affecting her ability to do her job properly. She was really embarrassed. She had really bad brain fog. She had sort of negative mood symptoms, lots and lots of menopausal symptoms. And it was just extraordinary because she went to her GP to say, well, can I have HRT? And was met with, as most women are in these scenarios, blanket refusal, despite the fact that she'd had her own hormones for 15 years and been absolutely fine. And despite the fact that she knew there was a risk, but she was willing to accept the risk, and it was her body. And she was terrified because she thought if she couldn't do her job, she'd lose her job. And if she lost her job, she wouldn't be able to pay her mortgage and she would have lost her flat. And if she'd lost her flat, she would have had to move in with her parents. She would have lost her independence. And there was just so many reasons to sort of listen to this woman and give her HRT if that's what she decided she wanted once we'd gone through all the, the pros and cons, etc. But I think this is the real problem, is that the moment there's a sort of blanket refusal and so many women, they aren't listened to, they aren't heard, they're dismissed, and they really struggle to access any care sometimes, never mind conversations about vaginal hormones, HRT and so forth. So I'm not sure if that's a good answer, but it's those kind of stories that have really motivated me to learn more about the role of HRT within menopause care, both before and after breast cancer, actually.
I think the point you bring up that people often forget about is that not only is it about health, right, but it's about livelihood. It's about how are you going to make ends meet. It's about your whole life, right? Hormones affect every part of your body and your mood and your ability to do things. And so when you're not able to function, you're not able to function at work, you're not able to function in your social sphere. And so it really is a whole body experience. And so, we minimize hormones to just, oh, it's just, like estrogen or progesterone, but we forget the impact it has on the body and how, if you're not able to function, like you just said, it affects your whole life. And that's exactly what you're talking about. So absolutely.
Quality of life, isn't it? It's not just about longevity. Of course, we'd all like to
Right.
live, but it's health span and lifespan. And I
Yeah.
do think oncologists and breast specialists are starting to recognize that there is more to a woman than a pair of breasts. I think women's brain health, cardiovascular health, bone health, all these things are also important and also need to be factored into these type of decisions. I attended a lecture recently at a conference given by a urologist where he was talking actually about prostate cancer in men, and he was talking about the trade-off that men are willing to make to accept a small increase in risk of their prostate cancer progressing in exchange for not becoming incontinent of urine, in exchange for maintaining their sexual function. And I was looking around the audience and no one was batting an eyelid. And I was thinking,
Yeah.
how is this okay for men? How is it
Yeah.
that we all recognize how important sex is for men, and being able to pee when you want to and how you want to is important for men, but no one is thinking about these things in women? Why is there such a double standard? It's so unfair.
Yeah, absolutely. Absolutely. Right. And when, women that have had breast cancer are worried about their sexual function, right? People think that they're being selfish or, why do they even need that? And I, agree with you 100% that it's not even looked at twice, right? Nobody even is asking the men, like, why do you care so much about your sexual function, right? It's always about women. And nobody is saying to them, well, you should be so grateful that you're alive, right? That's a comment that you hear a lot for women that have had breast cancer. And so now in your clinical practice, how do you tailor your, hormonal discussions with breast cancer survivors where the risk and the benefit conversations are nuanced and often emotionally charged?
Yeah. So these are my favorite consultations. And actually the sort of menopause aspect of it is the easy bit. It's the rest of the consultation that is so nuanced and can be so challenging in these patients. And I think, as with any consultation, it always starts with taking a history and listening to the patient in front of you. And I've had patients burst into tears in the consultation just because I'm the first person that's listened to them and allowed them to speak about their symptoms and their experience. So from my perspective, I'm interested in knowing why they've come to see me. Why are they potentially interested in HRT? They might not be interested in HRT. They might be interested in other treatment options. They might just want to talk through their options. Everybody comes with a different agenda. But if they are interested specifically in HRT, which a lot of my patients are by the time they come to me, then initially I want to know, well, what would the benefits be for you if you decide to take HRT? And then the next bit is obviously talking about the risks and recognizing that there is a risk if you take HRT after a breast cancer diagnosis. But the magnitude of the increase in risk varies hugely according to the type of breast cancer that you've had. And women who've had DCIS are not the same as women who've had estrogen receptor negative breast cancer. And they are not the same as women who've had estrogen sensitive breast cancer. And even among women who've had estrogen receptor positive breast cancer, the degree of risk will vary hugely because it depends on the size of the tumor, the grade, the stage, lots of other factors that will influence their future risk of relapse. So having sort of talked through that and trying to get a feel for the risks and benefits, I will try to quantify that for patients as much as I'm able to. And at the moment, we use an online tool called Predict. I don't know if you use that in your consultations. It's a great tool. It was developed. It's not been developed for this purpose. It's not validated for this purpose, but it's a tool that was developed in Sheffield, in the UK, the University of Sheffield. You can Google it, Predict online. And it's designed for oncologists to calculate the benefit, so the 10 and 15 year survival benefit for their patient if they choose to take either tamoxifen or an aromatase inhibitor for 5 years or 10 years. And it's great because it means you can look at the benefits and you can say to the patient, or I can say to the patient in front of me, look, if you take tamoxifen or if you take an anastrozole or whatever it might be, if you take it for 5 years, in 10 years' time, the survival benefit might be 1%, it might be 2%, it might be 5%. It depends on the original tumor. And therefore, if we can say that, well, taking away your hormones and not allowing you to have estrogen has a 1 or 2 or 5 or 10% risk in terms of your future risk of dying from breast cancer, then logically, allowing you to have your hormones is likely to have the opposite effect, either because you choose not to have that treatment, you don't like the side effects, or for whatever reason, and you've got your own estrogen, your periods restart, then you lose that 1 or 2 or 5% benefit. Or if you're postmenopausal and you decide to have HRT, then again, it will be associated with a 1% or a 2% or 5% increase in risk, depending on the patient. And then it becomes that, that's where it gets interesting, because how women perceive risk also varies hugely. And some women are very anxious, and even a 1% increase in risk would be totally unacceptable. And I completely understand that. But some women will look at a 2% or a 5% increase in risk and say, do you know what, I'm okay with that. I accept that it's not perfect, but I will accept that there will be a small increase in risk in exchange for having my quality of life back. And it will depend on the severity of their symptoms and other factors that have made them come and see me in the first place. So it's about recognizing the risks, quantifying the risks, and then supporting women to weigh that information up so they can make an informed decision that is based on their own personal history. So everybody is different, and everyone will think differently about it. And talking about other treatment options, like I said, if they're available, there are lots of things you can do. It also depends on how recently the breast cancer diagnosis was, whether women are still receiving treatment for their breast cancer or not, whether they've finished their treatment, other things they might be worried about, principally bone health, etc. So there are lots of other things that we might bring into that conversation, but it's about trying to give women accurate evidence-based information so that they can weigh the information up and decide for themselves whether they want to have HRT or not.
I read an article recently. It was in the Green Journal here, the American College of OBGYNs, and somebody had looked at, it was a narrative review of basically the literature and looking at in women that had like BRCA1 and 2, if they had their ovaries, right? So they had a risk reducing ovaries. So they had an oophorectomy, but they haven't had cancer yet. So they kept their breasts. And the literature, it looked at the literature about whether or not, how to manage their menopausal hormonal symptoms. And it talked about maybe having a conversation with women about having their uterus removed as well, so they wouldn't have to take a progestin. But oftentimes, we do the progesterone, but they had just, suggested, based on looking at the literature, that we know that estrogen actually decreases your risk of breast cancer, right? And decreases overall mortality in women. And so they were saying that if a woman is going to have a risk reducing bilateral salpingo oophorectomy, that perhaps consider having a hysterectomy with that. So have the uterus as well as the tubes, as well as the ovaries removed, so that they're only taking the estradiol, only the estrogen, and that would be helpful. What do you think about that for those individuals that may have BRCA1 and BRCA2?
Yeah, I think I would recommend that as well. If someone's going to have an oophorectomy and have their ovaries removed, I would also recommend having their uterus removed. It's not just type of breast cancer that it will influence your future risk if you choose to have HRT. It's the type of HRT really matters as well. There was one study, a slightly odd study, that was done about 20 odd years ago. And for some reason, it recruited women mainly with estrogen receptor negative breast cancer. And it gave them, it was Premarin, conjugated equine estrogen, so the old-fashioned HRT, and the risk of relapse was significantly reduced in those women who were given HRT compared with the women that were not. And I think it was something like 13% amongst women who did not have HRT whereas the relapse rate was only about 3% in those that did. So I think if you've not had breast cancer before, we know in women without breast cancer, their risk of breast cancer, developing breast cancer, is lower if they use estrogen-only HRT. And there is some very limited data suggesting that in women who have had breast cancer, estrogen-only HRT might reduce their risk of getting a second breast cancer. And equally in BRCA patients who haven't had breast cancer before, they're sort of in an in-between category, aren't they? Where, I think it's really important to distinguish between relapse and second breast cancer, because those are two separate risks when you've had a breast cancer diagnosis in the past. So if you haven't had breast cancer, you're in the first category, where really you're just trying to reduce your risk of getting it in the first place. If you've had breast cancer, then your risk of relapse is likely to be, I would say, increased if it was estrogen receptor positive within the first few years of your breast cancer diagnosis. But your risk of second breast cancer might be decreased actually if you take HRT within 5 years of breast cancer diagnosis. There's also data, it's called the estrogen paradox. I don't know if you've heard of this, but we know, for example, so before tamoxifen came along, estrogen was used to treat breast cancer, and women were commonly given high doses of synthetic estrogen, and it had about the same efficacy as tamoxifen. It reduced risk of breast cancer relapse by about the same amount. And the only reason it was superseded by tamoxifen was because tamoxifen was better tolerated and had fewer side effects. But we know that if you give estrogen to postmenopausal women who are sort of 5 or 10 years beyond their original breast cancer diagnosis, again, it seems to have a paradoxical effect. Rather than increasing the risk, it's decreasing the risk. Now, I don't know, because there's been so little data, but I'm really interested to know, are we talking about relapse? Are we talking about second breast cancer? As women age, things change, the tumor environment, microenvironment changes. There's so much we still don't know. We really need a big clinical trial looking at all of these types of outcomes in different women with different breast cancers using different types of HRT, over time. We need to try and collect this data because nobody has.
Yeah, that's amazing. And it's so nuanced, right? Just from everything that you're talking about, whether or not people have had breast cancer, not had breast cancer, BRCA, this and that. For those individuals that may be listening or watching this and not sure what you mean by when you talk about, estrogen positive, estrogen sensitive, estrogen negative, perhaps you could just, talk a little bit more about that and what that means.
Yeah, so broadly speaking, there are 3 main types of breast cancer. We have carcinoma in situ, which is not an invasive breast cancer. So carcinoma in situ is when you have cancer cells in your breast that haven't yet invaded into the surrounding breast tissue. So it's really interesting. People think that there's a sort of linear temporal relationship, and over time, DCIS becomes invasive breast cancer, then it metastasizes. Not true. If you did autopsy studies, there have been autopsy studies looking at women in their 40s and 50s, and lots of us have DCIS. Sometimes it goes away by itself, sometimes it progresses, sometimes it just stays there and doesn't really do anything. The problem with DCIS is not that it can relapse in the future if you've had it treated, or progress if you've had it treated. The problem is it's a risk factor for just as obesity is, or drinking too much alcohol is, it's a risk factor for getting breast cancer in the future. So you have to bear that in mind. These women have just a higher baseline risk of getting breast cancer, irrespective of whether they have HRT or not. The HRT is not related. But then invasive breast cancer is the type of breast cancer that can progress, grow, invade into the breast tissue and potentially spread to the lymph nodes and other areas in the body. And in postmenopausal women, about 80% is estrogen receptor positive. That means the tumor cells have got estrogen receptors, which is not surprising. It's breast tissue. Breasts do have estrogen receptors in them. Everybody knows that. In younger premenopausal women, I think it's about 60%. So broadly speaking, 3/4 of breast cancers will be estrogen receptor positive. And overall, based on available data, we don't think that estrogen causes breast cancer. But if your cancer has estrogen receptors, it is stimulated to grow and will grow more quickly if there is estrogen in the body, whether it's your own estrogen or whether it's HRT. Estrogen receptor negative breast cancer is the other 20-odd%. And those tumors, as I said, don't have estrogen receptors. So they're not treated in the same way. You wouldn't give them anti-estrogen treatment in the same way as you would estrogen receptor positive breast cancers. And, the HRT cannot increase the risk of relapse of an estrogen receptor negative cancer in the absence of receptors. It's got nothing to bind to and stimulate. So I sort of touched on that slightly earlier. The risk profiles are very different depending on whether there are estrogen receptors there or not when you're talking about HRT.
That's phenomenal. Thank you so much for explaining that. That was more for me than for the audience. I was like, please explain this to me. Okay. So, you often highlight the importance of precision medicine and menopause care. What exactly do you mean by that? In what context? And how do you think it differs from, like, say, like a standard approach that someone may take to somebody coming in for hormonal therapy?
Yes, I think historically, because we've used lots of oral HRT, synthetic hormones, it's a bit like the pill. Women come in and if they want HRT, they're given a standard dose or formulation and it either helps or it doesn't. One dose, one tablet, job done, easy peasy. By precision HRT, what I mean is tailoring the HRT dose and regimen to the patient. So increasingly over the last 10 years or so, women are turning to transdermal estradiol formulations more and more. So transdermal are preferred because they go across the skin. So these are patches, gel sprays, and they don't increase the risk of blood clots or stroke or PE. Whereas oral estrogens, if you take them, they are metabolized as they pass through the liver, and there's a small increased risk of blood clots, stroke, and PE. So because the transdermal formulations are safer, they're increasingly preferred, and more women are now prescribed these transdermal formulations. They are better. Estradiol is a body identical hormone as well, so it's better tolerated, fewer side effects. The only downside is that absorption of estradiol across the skin is very variable. So there's no one size fits all dose that's going to work for all women. And in fact, we published a study that was published earlier on this year in menopause in February. And we looked at about 1,500 women and we measured their estradiol levels by dose in all those women. And we showed that there was huge variation. And across the dose range, you've got women on low doses with high levels, women on high doses with low levels. Lots of things to consider when you're measuring blood levels in women, which I won't go into now. But the point is that there was huge variation. And in our study, in the cohort that we studied, up to 1 in 4 women had low levels, even though they were on the highest licensed dose. So potentially up to about 20-25% of women will not achieve therapeutic hormone levels, even with the highest licensed dose. And therefore, you have to offer them either a higher off-label dose or try something different. Depends on the patient which they prefer. So when we're talking about precision hormone therapy, what I'm saying is we've got to be aware that everybody is different. Everybody absorbs hormones differently across the skin. We metabolize them, clear them from our bodies differently. Other factors will affect our hormone levels. And what we need to do is tailor our treatment to the individual to ensure that all women can achieve therapeutic hormone levels, not just those women who are lucky enough that they can absorb it across the skin really easily.
Yeah. So what would you say is the therapeutic level that you're looking for? So, this is a question that often comes up in like these Facebook, OBGYN mom groups. And they want to know what is the therapeutic level to preserve bone, right? Then the level to make bone. And then what is the level just that's, for maintenance? So what would you say are those levels?
So this has not been clearly defined. There is no consensus. It's extraordinary. We're in 2025 and we still don't know what a normal level is for a woman. It very much depends on how it's measured. So in clinical practice, and if this gets boring, you can just stop me. But in clinical practice, there are 2 main ways that we measure serum estradiol levels. So usually, and I know in the States, because I read this the other day, 99% of the time we use something called an immunoassay. And immunoassays are great because they are quick, they can be automated, so they're good for high throughput, they're cheaper, and that's why they're generally preferred. But immunoassays have low sensitivity and specificity, which means they're not very accurate at low levels. And lots of things can give falsely elevated results when you're measuring levels using an immunoassay. So you have to be aware, and if there are any other menopause doctors watching at the moment, there was a great paper published in Menopause very recently by Frank Stanzik that summarized the differences between immunoassay and the other method that is better but much less commonly used, which is mass spectrometry. And mass spectrometry uses preceding purification steps. So we get rid of all those things that might interfere with our blood sample and cause a falsely elevated level. And it's much more accurate. It's much more accurate in postmenopausal women with very low levels. And it's just better. But only 1% of labs in America use it for monitoring serum estradiol levels. It's more expensive. It's not widely available. So when we're talking about an optimal level or a therapeutic range, it really depends on what you've used to measure it. And you have to really be familiar with the limitations of the methods used so that you can account for false high results, spurious results, etc. If I'm using immunoassay, which I usually am, because that's what I have access to, then broadly speaking, I would aim for somewhere between 200 and 600 picomoles per litre, which you're going to ask me in picograms per mil, and off the top of my head, I can't remember, it's about 55 or something like that. So between 200 and 600 picomoles per litre would be the general target range. I should also say that you don't need to do blood tests if women are using licensed doses and their symptoms have got better and gone away. You wouldn't need to do a blood test. This is for women who maybe have started on HRT, but their symptoms haven't improved and you're wondering whether they're absorbing it, or maybe you're trying to distinguish between side effects of HRT and menopausal symptoms, because sometimes they overlap. So things like bleeding, nausea, headaches, sometimes you can't quite know whether it's a symptom or whether it's a side effect. It's also really useful in younger women and women with osteoporosis or osteopenia if they don't have any symptoms. So if they're taking HRT because they've had a premature menopause, or if they're taking HRT because they want it to protect their bones and they've got no menopausal symptoms, how do you know how to titrate it unless you use blood tests and have a look at their hormone levels? So broadly speaking, with immunoassay, I would say somewhere between 200 and 600, depending on the patient. If I was using mass spectrometry, which I never have just because it's not available to me, but if I was, then lower levels are likely to suffice. And again, off the top of my head, I think it's above, I'm going to get my units muddled up, I think it's above 55 picomoles per litre. I'm actually writing something about this at the moment because there's been a lot of confusion and a lot of controversy, certainly in the UK. I don't know if there has been in the States, and people getting very anxious about using higher doses and off-label doses, and just not understanding that the main reason we do that is because those women are poor absorbers and have low levels, and if we don't give them a higher dose, they're never going to get better, and their bones will never be protected if their levels aren't in the optimal range. So a long answer probably to your question, but basically it depends on the method used, but broadly speaking, above 200. If it was mass spectrometry, a lower level may suffice, but very limited data there to sort of inform what the optimal level might be.
Amazing. Love it. So your recent study, I know you've done actually quite a few studies and published quite a few papers, but highlighted that women post breast cancer report poor quality menopause care. But those seen by specialists had better outcomes. What surprised you most about these findings?
Well, not that bit. Women get better menopause care when they see a menopause specialist. I guess, so this was a survey that we did. We ran it last year, and we advertised it online, and 1,195 women responded to this survey. These are all who had a history of breast cancer, and we were specifically asking them about their experience of menopause care after breast cancer. And not surprisingly, because there's a selection bias when you do this type of survey, clearly women who are more symptomatic are more likely to reply to this kind of survey. Women who are more interested in menopause care and HRT are more likely to reply to this kind of survey. But amongst those women, the symptom burden was very, very high. So about 98% of them, I think, had symptoms. And something like, I think it was 3/4 said they were either moderate severity or severe. So they were really significantly negatively impacting on their quality of life. That didn't surprise me because we've done studies in the past. We know that going back 20, 30 years, we know that this population can really struggle after breast cancer diagnosis. I guess what did surprise me was that really, despite knowing this for a long time, nothing has really changed in the last 20 or 30 years. And these women are still struggling, and they're still not being helped. And they still don't feel supported. They're still not being referred to menopause specialists. As you just said, we demonstrated that women who see menopause specialists get better quality care. But in this study, despite the fact that 98% of them had menopausal symptoms, only something like 17% had been referred to a menopause specialist. That's shocking. It means that women who can afford it will go to seek care in the private sector. That's fine. And I guess the thing that shocked me probably the most in that survey was some of the comments that women left behind concerning their care. I wrote down some of the quotes to read them out to you. So, for example, there was one that said, "What a battle when I had been through so much and was feeling so unwell. I honestly wanted to die. It was so awful." Another patient was told that the gynecologist consultant said anyone that prescribes her HRT should be struck off. Another breast surgeon told his patient that no reputable doctor would give HRT to her. Another one asked for it, and her doctor said he was not prepared to lose his 40-year career over giving her HRT. That was the end of the discussion. Another doctor said she would have to suffer. She just can't have it. And another one said, "It makes me incredibly angry that none of the medical team explained about an early menopause, what symptoms I might experience. I've always been a confident person who enjoys life. It completely broke me." And when I challenged the medical team, they just said everybody is different. And therefore they don't give out any information about it. And I think the thing that shocked me was, I guess, and this tallies with my clinical experience, just women feeling unheard, abandoned, unsupported, dismissed, gaslit, women receiving either inaccurate information or outdated information or conflicting information or no information at all. And just how women are spoken to and treated, I think. And I must just briefly add, by the way, this is all different types of doctors. Oncologists are not mean people. And oncologists have been trained, they're very nice people, and oncologists have been trained to treat breast cancer. And, their marker of success is getting rid of the breast cancer completely and it never coming back. And that is what they are completely focused on. And it's what they should be focused on. That's their job. It's just that, as I said earlier, it's not just the breast cancer. And most women diagnosed with breast cancer nowadays, thank God, will survive long term. Most breast cancer is picked up at an early stage, and most women will survive and go on to live, normal lives and have normal life experiences. And it's just recognizing that, there are increasingly tens, hundreds of thousands of women worldwide who've had breast cancer that potentially might now be really struggling. And it's just not really good enough to say, well, you're just going to have to suck it up because there's nothing that can be done. That's not true.
Right. Absolutely. And you're absolutely right that I think that, finding the right practitioner that's actually going to listen to them and help them manage their symptoms, right, will do a lot when we look at just what you were talking about, a health span versus lifespan, right? And how do people live as they get older, especially after a breast cancer diagnosis. So you recently co-authored chapters in Principles of Precision Hormone Therapy, which, by the way, I ordered and is coming through Amazon, Therapy for Healthy Aging. Now, what key messages from that work do you think clinicians and patients should take away?
Yeah, okay. So there were two chapters. The first chapter was more about the science. And I think making the point that estradiol, progesterone, testosterone have effects beyond women's reproductive system. And of all the symptoms that women get in menopause, their period stopping is really not something that usually bothers them. Most women quite like it when their period stop. Yeah. It's not that big a deal. Sometimes it can be problematic, but usually it's a good thing when women's periods stop. Okay, and what we're talking about, we have hormone receptors, estrogen, progesterone, testosterone receptors throughout our body. They are doing things in multiple tissues and organ systems. It's therefore not surprising that women experience menopausal symptoms that affect their whole body: the brain fog, the mood symptoms, the fatigue, the sleep, headaches, migraine, palpitations, gut symptoms, joint pains, muscle aches. There's loads and loads of menopausal symptoms. And if you're not aware of that, you'll miss the diagnosis. And I'm sure, I know I've done it in my past career. I'm sure I have. The number of times I see a patient who's had maybe palpitations, so they've been referred to the cardiologist, everything is normal. So the patient is told she's fine. She's not, she's having palpitations. Or, someone who's started developing migraines and headaches, and they've been referred to a neurologist, and they've had a CT or an MRI, and they've been told they're fine, it's all normal. They're not. They're having headaches and migraines, and just no one's thinking about their hormones. So the gist of the first chapter is to say, look, periods, yeah, absolutely, but actually please think about the bigger picture, and please think about women more holistically when you're talking to women about these things. And the second chapter is a chapter I wrote actually to accompany a visual aid that I made a couple of years ago now. And it's available online. If you Google my name, I think Glynne, visual aid, menopause, I don't know, it'll probably come up. I can give you the link afterwards.
That would be great.
Yeah. And essentially it was a sort of reaction to the fact that I've seen a few infographics and visual aids that are really good, but they essentially talk about women's risk of breast cancer if they take HRT, and they compare it maybe to if you drink more than 2 units of alcohol a night, or if you smoke, or if you're obese, or etc. But those infographics, they only talk about the old-fashioned sort of synthetic hormone formulations that we don't do so much nowadays, and they don't also present the benefits of taking HRT. So essentially you're giving something that's very negative, not really putting it into context very well, and not thinking about the benefits. So how can women make an informed decision? So I made these visual aids, and they put the risks into context, because even with the old-fashioned synthetic hormones, actually the risks were very small. They still can be used. They're not, often the benefits will still outweigh the risks, even with Premarin, if that's what women want to take. If they prefer an oral tablet, that's fine. But it also talks about the benefits, and we don't have large clinical trials when it comes to looking at body identical hormones, transdermal estradiol, body identical progesterone, nicer, safer hormones. We don't have clinical trials, but we do have accumulating observational study data. So recognizing the fact that these are not as good, recognizing the fact that they are not definitive, and we do need randomized clinical trials, it's just looking at the best currently available data and saying, look, if this is true, this is what this observational study found, then actually, your risk of heart disease will be much lower, even with the old-fashioned hormones, actually, up to a 50% halving of cardiovascular risk and risk of coronary heart disease. Your risk of diabetes will be reduced by 30%. Your risk of dementia may be reduced by about 30%. Big meta-analysis a couple of years ago. Obviously, osteoporosis. And if you're younger and you use body identical hormones, the benefits may be greater. So it's sort of talking about that. So the chapter just goes into that in more detail and presents the evidence that I use to make the visual aids, and talks a little bit about tailoring dose to the individual, as we talked about earlier.
Amazing. Now, I think you actually just kind of mentioned this a little bit, but you've developed patient resources, which one of them you're talking about this chart, and contributed to medical education. What gaps in menopause education among healthcare providers frustrates you the most, and how can we fix them?
I think the thing that frustrates me the most is just that most doctors' knowledge. I qualified in 1999. The Women's Health Initiative study, which I'm sure you've talked about on your podcast before, was published in 2002. So most doctors, that if we got any menopause training at all in the 90s, which we didn't, but if we had, the only thing I ever remember being told about HRT was, don't prescribe it, and if you do, it's the nearest dose for the shortest time possible.
That's what I'm saying. Yeah.
Mm-hmm. So my biggest thing, since, we're 20 odd years further down the line now, our knowledge has evolved, HRT has evolved, opinions have evolved. There are safer, better HRT formulations you can take. There's a lot more we know now. And my biggest thing would be just, it's such a shame. And I'm sure you get it too, so many patients, and, potentially I'll advise them, but then they'll go and see their GP or a different doctor, and they'll get told something completely different that I know is not true. But the poor patient gets caught in the middle, not knowing who to believe, because she's being now given 2 different pieces of information. And I find sort of having to defend myself and trying to sort of, I talk about evidence a lot with my patients actually in my consultations, and it just takes so much time sometimes, going backwards and unpicking. I would not presume, if a patient of mine has seen a cardiologist and been advised to take a certain medication or do a certain thing, I wouldn't presume to say that's not true, you shouldn't do that. I'm not a cardiologist, and it's really frustrating when the same courtesy is it extended to menopause doctors, because I think menopause is viewed very differently. Everybody's got an opinion. Lots of people are quite judgy still about it. And that would be my biggest thing for sure. Just everybody, it's 50% of the population. Everybody should be upskilled and updated in their menopause care.
I agree with you 100%. I think that so many doctors are still not willing to be updated, right? I don't know if that's still the case, for you in the UK, but here I can tell you just locally, even, when I go speak to practitioners, when I go speak to like internal medicine or family practice or different doctors, they just say, I don't have enough time, or I'm just not interested. I will tell you, I had a patient come to me that was, had gone to another doctor who was actually seeing a gynecologist, and she told him that she was having vaginal dryness. Do you know what he told her to do? He told her, and this is a gynecologist, he told her to put Crisco in her vagina every single day for her vaginal dryness.
Crisco.
It's a cooking oil, like it's a shortening, like that people use to make like pies.
Right.
He told her to use that every day.
I hope she didn't do that.
Yeah, and I was like, "What? He told you to do what?" And she said, "Yes." She said, "He's," and she goes, "I kept telling him I'm still irritated, and I don't think the Crisco is working."
Yeah, it's
And
extraordinary, isn't it? When does that ever happen? In what other field of medicine does that ever happen, where you're literally coming out with old wives' tales or just made up stuff? I don't know where he would have got that.
Yeah. I mean, it was crazy, and I was just I sat there for a while just in shock, because I couldn't believe that he was telling her to put Crisco in her vagina, and she was listening to him because she thought, he's a gynecologist, he must know what to do for this vaginal dryness. I mean, it just blows my mind. I just think it's crazy that we're still talking to women like it's I don't know, the 1920s or something. I don't know. It's really crazy.
And it's also the unnecessary investigations and appointments and healthcare costs that are incurred as a result of this. I remember I had one patient who came to me and lots of menopausal symptoms, obvious to me from the start that it was likely to be perimenopausal. And I counted up after she'd left, she'd had something like 200 odd different tests. She'd had every part of her body scanned, imaged, looked at, blood tests.
Wow.
She'd had everything done. She'd seen about 60 different doctors before. She'd just been referred to specialist after specialist and been told that everything was fine because nobody could find anything. And no one had suggested it could be that you might be perimenopausal. It was on no one's radar. None of those doctors had even thought about it. And you don't have to be an expert. You don't have to talk to women about their perimenopause. You don't have to prescribe HRT if you don't want to, but just be aware of it and maybe suggest, it could be this. Why don't you go and see a menopause specialist and start there, because common things are common.
Yeah, absolutely. You're so right. So, I know that you're co-chairing a working group on menopause management after breast cancer. What key principles are emerging, do you think, from this effort that could change guidelines in clinical practice?
So this really relates to this. So we've got a really big paper, should be published very imminently. So, I'm hoping in the next few weeks. And this is a large piece of work that I've been involved in it's taken over 3 years. And there've been a group of us, but the paper has been written by myself and Professor Jayant Vaidya, who is a breast surgical oncologist in the UK. And essentially, as we were saying earlier, we know that a lot of these women are struggling. We've known it for decades, but nothing is happening. So the aim of our study was to look into and define the role of HRT after breast cancer and review the evidence and write some consensus statements and sort of try and pull together all this information to support doctors and clinicians to counsel women more effectively, so that they can be supported to make these decisions for themselves, because there's a real disconnect at the moment between what doctors think women want and what doctors think women need and what women are actually asking for and what they may need. And it may be that when you've had a conversation and you've gone through everything, it may well be that they'll take that information away and say, actually, do you know what, on balance, HRT is not for me. I really valued hopefully having the conversation, but that's really helped me to decide. And now I'm not anxious that I'm missing out on something, or that's something I should be doing. But like I said, most women that I see in my menopause clinic, they are low risk. Women aren't stupid, funnily enough. They don't come and see me if they've had nasty, aggressive breast cancers. Women don't want to take that risk if they think there's a high risk associated with HRT. But if your risk is very small and if you're really struggling, there's no reason why you can't make an informed decision to take HRT if that's what you feel is right for you once you've weighed up all the pros and cons. So that's the biggest thing. We just really hope that when this paper is published, it's going to move the conversation forward. We hope that women can take it to doctors, so next time they're shut down, they can say, but look, there's a paper that says if you can talk to me about it, I'm allowed to ask about it, and there are options that can help me. And hopefully women who are struggling to access HRT and they've decided they want it, it will help them get it, because there is a group of us, it's a multidisciplinary, multi-international group who are saying, look, if women can make their minds up for themselves, you just need to make sure they've been given the accurate information.
Amazing. Absolutely. So where do you see hormone therapy and menopause management heading in the next decade?
So I really hope it's going to improve.
I know, me too.
I really hope that, lots of people are talking about menopause now. At some point, I really hope that other specialists are going to, get with the program and realize that things have changed and become more aware that HRT is really not that bad, and the benefits will outweigh the risk for most women. The menopause guidelines concur, that especially the modern formulations are very safe. And I think the other thing I really hope is that this sort of personalized approach to women's care is taken on board more, because I still meet lots of women who they basically come to see me because their symptoms might have improved a bit, but they're still struggling, and they've gone to their GP, and their GP has said, well, you can't have any more because that's the highest dose I can give you. Now, we do lots of things off label, off license, mainly off label in menopause care. Every time you give HRT to a perimenopausal woman, it's off label. If you're giving HRT to a woman, for her cardiovascular risk, it's off label. It's not licensed to do that at the moment. If you're giving testosterone to a woman for anything other than low libido, it's off label. But we do that because we have enough information, that we know what we're doing based on available data, and we're waiting for the clinical trials, and they haven't happened yet. So, you either sit there and wait, or you take a decision, if you're in clinical practice. So I hope that, doctors start recognizing that actually blood tests can be really helpful. If they are using blood tests, they do need to understand how to use them so they can interpret them properly. And hopefully women will start being able to access the doses they need rather than having to fight for them.
Yeah, that's like in an ideal world, right? Not have to fight for everything.
Yeah, we'll see. Yeah.
Yeah. So what role do you think digital health tools, we have AI and telemedicine, I'm sure a lot of people are already using, but definitely AI will play in like advancing personalized menopause care?
So it's an interesting one, isn't it? I don't know. I mean, theoretically, it's perfectly capable of doing a menopause consult. If you're a straightforward patient, you can fill out a form, and if you've got no contraindications, and I don't see any reason why these programs can't be made, to start women off on HRT. I'm sure that AI will be able to work its way around certain problems. I do think there are some cases I can't imagine AI will be perfect for, my breast cancer patients, women with potentially endometriosis or histamine intolerance, women who are, challenging for people like me, because they're difficult and it takes a lot more time to optimize their dose and level. And I still think that ultimately most people prefer to speak to a doctor, if it's anything beyond straightforward. Yeah.
Yeah, definitely. I mean, even with like telehealth and all of these, so many telehealth platforms for menopause care, so many women still, it's that personalized approach, right? It's just that face-to-face conversation that people enjoy, that human touch that I think that you don't get over a screen, that people so desire. And especially when they've been dismissed and not heard for so long, to actually sit in a consult room with another person, I think does wonders, right, for your mental health. I think that that's really important.
And I think just picking up on those verbal cues as well, you might be talking to someone and, you'll just suddenly realize that they're not quite on the same page as you. And then you'll stop and you'll say, okay, let's, before we go any further, are we on this, are we talking about the same thing here? Was there something else you wanted to discuss? And patients themselves might not even know that until they get into a conversation with you. So we'll see. I don't know. I'm sure it will have a role, but hopefully it won't take over completely.
Yeah, that's right. So what's one myth about menopause you wish would vanish forever, like a giant billboard in London?
One myth.
You're like, there's so many.
Exactly. Probably with breast cancer, it's difficult because I guess I guess it's fairly well recognized now that estrogen doesn't cause breast cancer, because we know that women who use estrogen only HRT have a lower risk of breast cancer. There's still some controversy around the progestogen, and synthetic progestins may increase breast cancer by a small amount. Even that is, there are different takes on that data. Body identical progesterone does not appear to increase breast cancer risk in observational studies, but there have been no clinical trials testing that formally. So I guess the myth I'd really like cracked one way or another is, does HRT cause breast cancer? I do not believe that body identical hormones can cause breast cancer, but that's my opinion. So that would be the big thing I think that needs addressing and hopefully clarifying one way or the other.
Yeah. Yeah. So if you weren't a doctor, what do you think you'd be doing right now?
Painting. So I'm super busy. I'm all, with writing and stuff. I have no spare time. But before COVID, at one point, I was actually thinking of giving up medicine at one point, and I was getting really into art. And I love art. I've got arty children, and I'd started taking them to art galleries, developed a passion, started going to life drawing classes. Not very good, but just loved it. It's like a form of mindfulness meditation.
Yeah.
You switch off, you leave your phone in the bag, and you sort of surface 3 hours, 4 hours later. And I just loved it. And then COVID happened, and kids were, being homeschooled, and then my career sort of changed direction. And then I just haven't had time to do it now for several years. So I've always said, when I retire, that's what I'm going to do. I want to go back and I want to pick up where I left off. So if I wasn't being a doctor now, that's probably what I would be doing.
I'd love to see some pictures, some paintings. That would be fantastic. Should do a show and tell next time.
Believe me, you really don't.
So which book, podcast, or TV show do you turn to when you need to switch off from the clinic?
Oh gosh, so preferred reading anything. I love reading, always love reading anything. I don't read, I only read fiction. I'm not interested in reading factual stuff, and I know I should do, but I just love fiction. Anything. I'll read classics, I'll read whatever's top of the New York Times reading list. I don't mind. I've just read the I probably shouldn't admit to this, I've just read the Throne of Glass series by Sarah Maas. I don't know if you've read it.
No. Is it good?
Yes, it's sort of, read it. It's really, really good. And it's total escapism. And there were 8 books. And it took me through the entire summer.
Oh my God.
Yeah, loved it. Really good. But yeah, reading anything.
Amazing. And let's see here, a couple more fun questions. So if you could have dinner with any historical woman in medicine, who would it be and why?
So I was thinking about this before, because there's the obvious contenders. There's people like Franklin and Marie Curie, and the Florence Nightingale. There are all these names, and I was sort of doing a Google, and I came across a doctor called Mary Jacobi, who was born sort of at the end of the 1800s, and she was a doctor, therefore, in the early 1900s, at a time when women were not generally doctors, and the reason she caught my eye is at around that time, there was a male doctor, I think it was Edward Clarke, and he'd written some essay. And basically the gist of his essay was that women shouldn't be educated because we're having periods and we're very frail when we have our periods, and we shouldn't overtax ourselves. We should be resting. Otherwise, we're going to become puny and ill, and education could lead to infertility. And
of course. That's what it always does.
Obviously. And Mary Jacobi, I just loved it, because she saw, she obviously read this. She was outraged, not only because women should obviously have a right to an education, but also because this was an opinion, this was written by a man, and it was opinion, and there was no evidence to support his opinion whatsoever. It was presented as science. And so what she did was she thought, hold on, I'm not happy with that. I'm going to go away, and I'm going to, review the evidence, and I'm going to do my own experiments, make my own observations. And she charted things like heart rate and temperature and muscle strength across the menstrual cycle, and not surprisingly concluded that it had no bearing whatsoever on women's ability to do anything, especially, learn and be in education. And she won an essay prize at Harvard, and she was the first woman to win the prize. And I just thought, that's brilliant. That's what we should all be doing. We should all be curious. We should all be, there are huge evidence gaps in menopause care. There is so much that we could all be doing. And instead of just arguing about it and, presenting opinions and all the rest of it, do some research, find out, look at the data. So I love that. So that's who I would like to meet, I think, would be Mary Jacobi.
Amazing. And last question, I think I already know the answer to this one, but what do you prefer, tea or coffee, early bird or night owl?
So I'm British, so
Yes.
obviously I'm going to say tea.
That's right.
And early bird. My favorite time to work, actually, if I'm writing a paper, I get very absorbed and hyper focused on it. And so I'll wake up at 5:30. And my favorite time to work is, 5:30, 6 o'clock in the morning, when the house is quiet, the birds are singing, the lights coming up, and it's peaceful, and nobody needs me, nobody wants me, and I can just crack on. So early bird, 100%.
Oh, fantastic. Well, this has been such an amazing conversation, and I'm so happy that you were able to come on. And thank you for taking the time to come on. And for all of those people that are listening and watching and thinking, wow, Dr. Glynne is so amazing. I would love to be her patient. How can they get in touch with you? How can they reach out and perhaps become a patient of yours?
Absolutely. So I can't, because of insurance purposes, I can't see patients abroad. But if you're in the UK, if you've got an address in the UK, I'm based at the Portland Hospital in London. I work with Claire Mellon and Associates at the Portland Hospital. And yes, I'm there for a couple of days a week.
Amazing. Well, thank you so much for coming on. And I am so looking forward to your paper that's going to be out soon. Hopefully we'll get a chance to read it. And maybe if you have time, maybe we can have you on again. So that would be fantastic. Thank you again for your time. And well, we are done here, and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. If you have any questions about hormones, breast cancer, or anything else, make sure you go see your healthcare provider. And if you can't find one that actually listens to you, make sure you go to the menopause.org and find a Menopause Society certified practitioner that will take a listen to you and help you out. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.